Now, I want to start with getting everyone to look at this box of chocolates, and I want everyone to think of their favourite box of chocolates, and the ones that I've used are Kiwi's favourites. Now, I personally like a Moro bar, okay? And I don't know why, but I just hate Dream chocolate. If you ask me, I think it's imitation chocolate and it's not real. But that's just my preference, whereas my father-in-law loves white chocolate. And what I'm trying to get at and what I want you guys to reflect on is how we all have favourites, we all have preferences, and sometimes we don't know why, we've just come to them. So, my name is Rachel Russell and I'm a clinical educator as a part of the nursing team. I also work part-time still at the hospital on a surgical ward, and my research today is called How Transparent is Fair? The selection criteria for patients requiring elective surgery in Aotearoa, New Zealand, and how this affects access for Māori and Pacific peoples. So this research was undertaken, as I said, I still work in the hospital, and I was observing firsthand unconscious bias happening within the workplace. This led me to question the elective surgery process. Why are those who are selected for surgery selected? Who picks them? How is rationing of publicly funded health care consistently and equitably distributed by those making the decisions? Before I talk further about this, I just also want to acknowledge my positionality as tangatiriti. As a person of European descent living in New Zealand, my experiences are very different to tangata whenua. However, as a healthcare professional, it's not only my responsibility, but my obligation to ensure care is fair, equitable, ethical, and based on the principles of the treaty. So with this in mind, my aim was to explore how is clinical judgment and the use of the assessment tools used in the selection process for elective surgery, especially given the acknowledgement within our healthcare system of systematic racism and discrimination. And just for those that might not be aware of the tool I'm going to be looking at, is the Clinical Priority Assessment Criteria, which I'll be referring to as CPAC. Now, with this aim in mind, I realised I couldn't have one question. I actually ended up with 3 questions. So they were, what is the history of policy and management of access to elective surgery in Aotearoa, New Zealand? And what does the evidence say about how assessment tools are used to select the patients within the public sector? And based on these findings, what are the implications for Māori and Pasifika people? Now, to answer these 3 questions, I had to come up with a method. So the method that I actually chose was an integrative review, as it allowed not only a summary and analysis of past research, it also allowed me to come up with a comprehensive understanding of my research. A search strategy was conducted using available databases, key search terms, and an inclusion criteria. I was able to identify 13 articles that matched these requirements, which I then summarised into a table. These were then explored using thematic analysis to explore how healthcare professionals involved in this selection process are using the assessment tools. So, what did I find? I actually found a lot of micro themes that I was able to take and put into greater macro themes. So I was able to come up with 3 themes, and the 3 themes are: a difference was identified between how clinicians use the assessment tools. Theme 2, resource shortages and issues affect how the CPAC assessment tool is used. And theme 3 is clinicians' non-compliance to CPAC tools. Now, if I'm being honest, I did expect a lot of these findings. However, I did not expect or consider the implications for Māori and Pasifika people. So I'm now going to talk about the themes and these implications, but as I do that, I want you guys to reflect on this picture. So, theme 1, the difference identified between how clinicians use assessment tools. So, It is known clinicians have different approaches to practice, and research identified that how they use the cues and therefore demonstrate practice as a priority score is different. And what I mean by cues is I mean symptoms, diagnosis, family histories, how the surgeons weigh those up against each other is different. Also, on top of this, we found that the cues that some of them would use weren't even included in the assessment tools. And unfortunately, it was admitted by some clinicians that they alter scores to game a higher score and allow their patients to get through for surgery. So what are the implications of that? Well, what we know from research is that healthcare professionals in New Zealand unfortunately spend less time with Māori patients over non-Māori. We also know that Māori and Pasifika people are stereotyped more by healthcare professionals, and they are also judged unfairly for negative health behaviours such as smoking. So could this lead to disparities in the assessment and therefore access to elective surgery? When we consider these points and the fact that clinicians apply different weights to how they score and prioritise cues, and they've admitted to gaming scores, are Māori and Pasifika people unfairly overlooked from unconscious bias? This takes us to theme 2. So theme 2, resource shortages issues affect how the CPAC assessment tools are used. So this includes short staffing, resources and funding. They all affect access. And what happens when those are low is it changes thresholds, which means availability of resources and to provide the surgery is changed, meaning even if you meet the score and you are eligible to surgery, you may not get it. However, we need to look at this from the point of the patient. They may not have the resources either to get access to surgery. So when we think about this and the implications, Māori and Pacific people disproportionately live in higher areas of deprivation. They are often socially disadvantaged and they are victims of the unfair determinants of health. And we know that individuals who live in deprivation do not have the same access to resources such as transport and finances. Therefore, are Māori and Pacific people being discriminated against from a structural perspective of having less resources and funding within their communities, causing a barrier to elective surgery? When we look at theme 3, I would like you to really consider this one. It's clinicians' non-compliance of CPAC tools. So basically, due to surgeons, and they're well within their right, having concerns around their tools, they've either completely ignored them and they don't use them, or they've introduced their own tools. So the disregard and non-use of CPAC tools results in a loss of transparency in the selection process. And from research, we know that clinicians who really use clinical recommendations and formal information instead rely on things called mind lines. Now, mind lines is knowledge that's been gained through interactions with patients, readings, reinforced intelligence, early training, their experience, as well as that of their colleagues. However, through empirical evidence, it has been acknowledged that unconscious bias happens within our healthcare system. So, if we consider the implications of this theme, that surgeons who are disregarding policy and selecting patients at their own discretion, could they unconsciously be blocking access for Māori and Pasifika patients to elective surgery? So when I looked at this a bit closer and I was concluding my research, I realised that when you explore this in depth and under a lens of disparity, these themes have highlighted possible barriers and therefore put implications in for barriers of access for Māori and Pasifika people, be this conscious, unconscious, or simply the way it's always been and therefore the norm, it demonstrates inequities to access of care. From this research, I've identified the need for further assessment and auditing of the selection process for elective surgery in regards to accountability, transparency and fairness. The ongoing discussion around disparities of care for Māori and Pasifika people cannot be ignored, as it is not going to go away until the gap is closed. Addressing the inequities and inequalities is of particular interest, especially in the current political climate when we're seeing positive changes being reversed, meaning equity continues to be an ongoing challenge within healthcare. And I kind of would just like to link that back to a little bit of what Dr. Api was saying this morning. Whoever was there for his discussion, he did discuss some of these positive changes that are being reversed. But finally, I want to leave you guys with this quote to read. And as you read that, I want you to reflect on the box of chocolates and what your favourite might be. Thank you.